shift to the next session. Professor Amira, Professor Wafaa.
Professor Dai.
السلام عليكم. السلام عليكم جميعا. It's a great honor to meet my dear professors and colleagues today in IBG EDU 7th Wave, and I'd like to thank Professor Dr. Azzat for his kind invitation. Now we will present Professor Dr. Khalid Ali. He will talk about UC in pediatric. What is the difference? Welcome, Dr. Khalid.
Thank you, my dear Professor Wafaa. Thank you for all. It's my pleasure to be with you today, present my lecture to you.
Dr. Khalid, I hope Professor Amina here, Professor Amira Shams hear us.
Yes, I hear you now.
Yes, you are for the first time on our platform for IBG.
أيوة دكتور خالد أنا معاكم. And it is congratulations, but
بس احنا السكرين باين معانا حضرتك.
نعم
الفيديو مع حضرتك مش لينك معانا،
مش شغال، مش لينك. ايوه عشان كده اسك بس زي الو
دكتور خالد.
Yes, Professor Amira, I will start. Thank you. Bismillah ar-Rahman ar-Rahim. Today we will talk about pediatric UC. What's the difference? At first, as we know, ulcerative colitis is a chronic relapsing inflammatory condition of the colon from the rectum proximally. The incidence of pediatric UC, which form roughly about 15 to 20% of all patients with UC, ranging between 1 to 4 per 100,000 per year in most North American and European regions. And we have the childhood onset UC is extensive in about 60 to 80% of all cases, which is twice as in adults. IBD, as we know, combination of genetic, environmental, immunological factors, and the problem of dysbiosis leading to IBD. IBD, by the numbers, we have about 1.6 million Americans have IBD. Of them, about 80,000 patients are children under 18 years old, with about 70,000 new cases each year. This figure shows the geographical distribution about incidence of childhood onset UC per 100,000 per year in different countries. The pediatric IBD Porto group of the European Society of Pediatric Gastroenterology, Hepatology and Nutrition published what's called IBD, pediatric IBD classes criteria into 5 classes. We have pediatric Crohn's disease or CD, colonic CD, and we have ulcerative colitis and atypical ulcerative colitis, and what's called IBD unclassified. Sensitivity and the specificity of IBD classes to differentiate UC from CD and IBD unclassified about 80% and 84%, and to differentiate CD from IBD unclassified and UC was about 78 and 94%. Now I will talk about management of pediatric ulcerative colitis according to the ECHO guidelines and also the guidelines of European Society of Pediatric Gastroenterology, Hepatology and Nutrition. At first, how to assess and predict disease activity in pediatric UC. Recommendations: disease activity should be monitored at every visit utilizing what is called Pediatric UC Activity Index at diagnosis, before major therapeutic modifications, and for cancer surveillance, and when it's not clear if symptoms are disease related, especially if we have marker elevated like calprotectin, but it's not routinely indicated during relapses that are not severe. If available, fecal calprotectin should be obtained while in sustained clinical remission, and endoscopic evaluation should be considered when calprotectin is high. Clinical manifestations of UC, as we know, diarrhea, bloody diarrhea or rectal bleeding, urgency, tenesmus, mucus per stool, crampy abdominal pain, weight loss, fever, tachycardia. Severity of these symptoms very important, mild, moderate, or severe, which correlate with extent of disease and will affect my management of my patient. This is the frequency of symptoms with the most common bloody diarrhea or hematochezia. Children also have some unique related considerations other than in adults, like puberty, gross nutrition, and bone mineral density, and also psychological effect on children and their families. This is the Montreal classification for extent and severity of UC, and we can classify according to the extent. We have ulcerative proctitis, left-sided colitis, or extensive pancolitis, and also according to severity, patient in remission, asymptomatic patient, or mild or moderate or severe UC. This is the figures show with Montreal classification. And as we know, because disease extent has been consistently associated with disease severity, it's not surprising for us that pediatric UC has a worse disease course, with about 30 to 40% colectomy rate at 10 years, as compared with 20% only in adults. About 25 to 30% of the children with UC will require admission for an acute extirpation before transitioning to adult care. The use of Paris classification also advocated for phenotyping pediatric UC, and this is additional labels of very early onset IBD, less than 6 years of age, and also we have what's called infantile IBD and neonatal IBD in first 28 days of life. This is the pediatric UC activity index we can use to assess activity in pediatric UC, depending on different criteria: abdominal pain, bleeding, stool consistency, number of stools per day, nocturnal stool, the activity level of the patient, no limitation of activity, occasional limitation, or severe restricted activity. And we can classify remission when activity index less than 10. From 10 to 34, we have mild, 35 to 64, moderate, 65 and more, we have severe activity. Clinically significant response is defined as pediatric UC activity index change at least 20 points. Long-term prognosis is better in patients who achieve complete clinical remission during the first 3 months of diagnosis. Also, we have the Mayo scoring system for assessment of activity and for monitoring treatment response. Scores range from 0 to 12. We have less than 2 clinical remission, from 3 to 4 mild activity, from 6 to 10 moderate, from 11 to 12 severe activity. In Mayo score, we depend on bowel movement or bowel frequency, rectal bleeding, and also we have what's called endoscopic subscore for assessment of endoscopic activity. As we know, endoscopy is the reference standard to evaluate mucosal inflammation. And also we have what's called the modified Mayo endoscopic score, which combine also the extent plus the Mayo endoscopic score. This is the Mayo endoscopic score. We have a score 0, normal mucosa, score 1, just erythema, decreased vascular pattern, and mild friability. Score 2, we have marked erythema, absent vascular pattern, friability, and erosion. And the score 3, we have spontaneous bleeding and ulceration. Also, we have the ulcerative colitis endoscopic index of severity, which is validated to assess activity of UC in children. Don't forget CRC or colorectal cancer surveillance by trained endoscopist following 8 to 10 years of disease duration, except in case of primary sclerosing cholangitis. And according to the same for children, from endoscopy still can help us in case of screening. This is the endoscopic index of severity, UC endoscopic index of severity. What about fecal markers for assessment of activity? High correlation of calprotectin was present with clinical activity, endoscopic and histological indices in both children and adults. And given the fact that significant endoscopic disease may be present in about 20% of children with pediatric UC activity index less than 10, which means they are in remission according to pediatric UC activity index, but actually we have significant endoscopic disease. So it's reasonable to measure calprotectin in this group to assess the mucosal healing. And I can go to endoscopy if I have fecal calprotectin is high. Till now, we have no ideal cutoff value of fecal calprotectin, but cutoff value more than 250 more accurately can predict mucosal inflammation. Lab test biomarkers should be used to confirm endoscopic setting of primary sclerosing cholangitis, blood tests like CBC, albumin, transaminases, CRP, and ESR. Should be performed regularly depending on symptoms, at least every 3 months while on immunosuppressive medication, and at least every 6 to 12 months otherwise. Also, don't forget to test for renal functions in patients taking 5-ASA or mesalamine. In contrast to adult UC, high-sensitive CRP not suitable to differentiate between remission and relapse in children with normal CRP. Serum albumin level was the only significant lab test that was predicted for severe colitis in 1-year follow-up study. In another study, elevated white blood cell count and low hematocrit value measured at diagnosis associated also with colectomy. As regards the B-ANCA, about 60% of children are B-ANCA positive at diagnosis, and a recent Porto Group multi-center retrospective studies on more than 800 children with chronic IBD, they found that B-ANCA predicted the need for biologics in UC. This is the predictors of aggressive pediatric UC at diagnosis, pancolitis and severe colitis when pediatric UC activity index more than 65. This is the bad prognostic factors that can help us in assessment. What about medical management and how to manage patient child with UC medically? At first, 5-ASA and enemas. According to the recommendations, oral 5-ASA compounds are recommended as first-line induction and maintenance for mild to moderate UC. Combined oral and rectal 5-ASA is more effective than oral 5-ASA monotherapy. Rectal monotherapy should be reserved for mild to moderate ulcerative proctitis, which is uncommon in pediatrics. When rectal therapy used, 5-ASA is preferred over steroids. Only sulfasalazine available in liquid formulation also can be effective in case of arthritis, but as we know, we have adverse events of sulfasalazine. Suppositories useful for limited proctitis, while foam and liquid mesalamine enema can be for more extensive colitis. Dosing 5-ASA once daily can be considered for induction of remission and for maintenance. In the MAPIT trial, randomized the children with mild to moderate UC into once versus twice daily with comparable outcomes, no difference between 2 regimens. It's better to give once for better compliance, as we know. The effective induction dose should be continued as the maintenance dose. Maintenance therapy should be continued in pediatric patients. Treatment modification should be considered in patients don't show initial response within 2-3 weeks. Acute mesalamine intolerance could present as acute exacerbation of UC. This is very important. Usually occur within the first months of treatment and symptoms resolve within days of cessation. We have rectal tacrolimus may be considered in patients with ulcerative proctitis are either refractory or intolerant to mesalamine or steroid topical therapies. What about steroid? Recommendations: oral steroid should be used as second-line treatment for mild moderate UC not responding to 5-ASA and may be considered as first-line in the higher end of moderate disease. Severe UC should receive IV steroids, as Professor Allen said before. Second-generation oral steroids can be used in children with lower systemic effect, such as beclomethasone and budesonide multimatrix. Steroids are not recommended, as we know, for maintaining remission. A steroid sparing strategy should be applied for maintenance. Recommended daily dose about 1 milligram per kilogram body weight per day, maximum 40 for 2-3 weeks, and then we start tapering like this schedule. In patient more than 30 kilogram, dosing schedule of bipropionate about 5 milligram once daily for 4 weeks, and for budesonide about 9 milligram for 8 weeks. And we have no evidence to make tapering of these medications. We can stop them suddenly. The term steroid dependency applied to patients who are unable to stop steroids with recurrence of activity or who have relapse requiring steroids within 3 months of stopping steroids. Children with UC have more steroid-related complications than in adults, including osteopenia, glaucoma, cataracts, and also the problem of adrenal suppression in patients taking high steroid for long duration, more than 3 months. As we know, ECHO statement in adults suggests supplementation with vitamin D while on steroid therapy, but we have no clear evidence to support supplementation of vitamin D in those who are not deficient. What about immunomodulators? Thiopurines recommended for maintaining remission in children who are steroid dependent or relapsing frequently, more than 2 relapses per year. Also, thiopurines should not be used for induction of remission in pediatric UC. Measuring thiopurine metabolites is recommended in patients with incomplete response and in patients who present with leukopenia or elevated liver enzymes or poor compliance is suspected. Don't forget to make thiopurine methyltransferase activity to reduce the dose in heterozygous and avoid thiopurines in homozygous, with regular monitoring of blood counts and liver functions. Very important. The dose about 2 to 2.5 milligram per kilogram body weight for azathioprine and 1 to 1.5 milligram per kilogram body weight for 6 mercaptopurine. We should discontinue thiopurines if we have clinically significant myelosuppression or pancreatitis. What about withdrawal of thiopurines? We must weight the risk of relapse against the benefit of withdrawal, and we can consider withdrawal of thiopurines in patients with sustained clinical remission at least 1 year and better with histological remission. Methotrexate rarely to be considered in UC. What about biologics in pediatric? Infliximab considered in chronic active or steroid-dependent UC and controlled by 5-ASA and thiopurines. Adalimumab and golimumab also can be used, but have no role in patients with primary non-response to infliximab. They can help us in patients who initially respond and then lost response or intolerant to infliximab. Vedolizumab also can be considered in chronically active or steroid-dependent patient as second line of therapy after TNF failure. In children, also like in adults, don't forget screening for TB, virology. Also, in children, we may need high initial dosing of infliximab in children with low body weight. And also, we can give rapid infusion of infliximab over 1 hour with the same safety like slow infusion. We can give infliximab in combination with immunomodulators, as we know, to reduce the production of antibodies. And we can discontinue immunomodulators about after 6 months, especially in boys, after ensuring trough infliximab level. Don't forget measurement drug level and antibody in case of use of biologic treatment. Active disease with treated with infliximab or adalimumab, we must check for drug level and antibody. If we have negative or low antibody titer but low drug level, we can increase the dose or decrease the gap or frequency between dosage. If we have low level and high antibody titer, we can switch to another anti-TNF. If we have adequate level with no response, we can switch to another class. This is the monitoring of treatment in patient taking 5-ASA and or biologics, and how we can go to endoscopic evaluation depending on fecal cat protectin if elevated in case of clinical remission. I will escape this surgical consideration. Elective colectomy should be considered in children with active UC or steroid dependent. Restorative proctocolectomy and covering loop ileostomy is the recommended elective surgery in children. 3-stage procedure also is recommended for patients with acute severe colitis. And we can in children use the minimally laparoscopic approach. Please don't forget to exclude Crohn's disease before time of surgery. About extra intestinal manifestation in children, we have the problem of peripheral arthritis, which can be treated by first line with sulfasalazine and also anti-TNF. Primary sclerosing cholangitis and the screening by transaminases, GGT. Don't forget the ultrasound, MRCP, and their role in screening for primary sclerosing cholangitis and also for cholangiocarcinoma in case of pediatric UC combined with sclerosing cholangitis. The issue of nutrition, growth, and bone health is important in children, as I said before. Psychological assessment and psychological support very important also in pediatric UC, and we can use some measures like pill box regarding the medications to give help to patient to be compliant with our medication and follow up. Very early onset IBD in children less than 2 years. We must exclude allergic colitis, immunological disorders. The underlying genetic defects also should be searched for. This is the algorithm for treatment. This is summary of what I said before about use of 5-ASA, steroids, cypurines, and biologics. For acute severe colitis, I think we repeat the same as Professor Allen said before for acute severe UC or ASUC with some few differences in children. I will be rapid. Only recommendation. The most important I want to say in children in case of ASUC, it's very important to exclude infections as Dr. difficile toxins A and B should be done. Cytomegalovirus, very important, and other infections. Avoid non-steroidal anti-inflammatory drugs. Opiates with caution. Should exclude bowel perforation in these cases. Nutritional support is important. Thromboprophylaxis in children is an important issue, and we must make thromboprophylaxis only if we have one or more risk factors in adolescent, but before puberty, it must be used with caution. 5-ASA, no rule in ASUC. Antibiotics also, especially if there is infection only, otherwise we cannot give antibiotics. Steroid methylprednisolone is a cornerstone. It's better than hydrocortisone, given IV after hospital admission. Don't forget toxic megacolon should be excluded by X-ray. Even if X-ray is normal, but I have signs of peritonitis, I must proceed to CT and MRI to exclude toxic megacolon, which will need surgery. The second line therapy include also infliximab, anti-TNF, calcineurin inhibitor like cyclosporin and tacrolimus, where the role of cyclosporin and tacrolimus here in ASUC as a rescue therapy only, bridge for long-term maintenance. As we said before, infliximab in ASUC can be given in high doses, especially in children, and we can make a small gap between doses to give more response. Finally, this is the last slide, the algorithm for ASUC in children, and we make clinical assessment, admission for IV steroids, antibiotic, as I said, if there is infection, stop 5-ASA to avoid what is called mesalamine intolerance, and then assess in day 3 the pediatric UC activity index, more than 45, 35 to 45, or less than 35. If we have 35 to 45, I can continue to day 5, but if more than 45, I must screening for second line and prepare for second line therapy, anti-TNF and calcineurin inhibitors. At day 5, I make assessment for to start second line if more than 65, and also continue corticosteroid for 2 additional 5 days till I reach finally at day 6 to day 10 and make reassessment again. Thank you very much. Sorry for take more than my time. Thank you.
Thank you, Professor Khalid, for this elegant lecture.
Thank you very much. Any questions from the floor?
أنا دكتورة أميرة يا دكتورة وفاء. It is a very nice lecture. Dr. Khalid, this lecture could be make it in 3 parts. The symptoms, and sign, and then manifestations will, not the investigation, and then the treatment, because it is very, very well done lecture. Indeed. The question is, do you face youngest than the children, not the infant, at 6 months, 8 months, like that? You are not a pediatrician, but maybe in your experience or the youngest age.
I didn't see, but since few days, my dear Professor Azzat told me about case, I think 6 months or 8 months.
Yes.
UC, yes, infantile.
What is your procedure? You and the pediatrician, what is your procedure for diagnosis? I have a case, 8 months, 7 months, and the father has Mediterranean fever, and the mother has non-specific colitis. This young, the young infant started to some diarrhea and some bleeding per rectum, and they examined the pediatrician, no polyp, no fissure, no nothing external. Do you think of over UC at that age?
In this age that I said,
calprotectin,
yes.
and pediatric endoscopy, colonoscopy.
بس هو يعني at age less than 2 years or early onset or very early onset, you see, we must exclude, as I said before, the genetic factors, immunological factors, immunological disorders,
allergic. Yes, you said, you mentioned.
Yes. لازم نعمل يعني genetic analysis for this patient, and I think we can proceed for diagnosis for colonoscopy.
طب Dr. Azzat, what, why he refer this patient to you, the young patient, the children, the child? For what reason? What is the aim?
No, we didn't refer. We're just talking about this 8 months baby with UC, and I think with our colleague at Cairo, they took a study for his microbiota and send genetic outside because it's very early to be registered in Egypt, between 6 to 8 months. I think in a very early case. So we are interested to follow the case and to assess if there is early genetic change. We call it very early IBG, very early onset IBG. It's beyond the pediatric, it's infantile type.
Yes.
Do you think, Dr. Azzat, that patient, I can refer, the pediatrician doesn't do any good result with this baby?
Yes.
Do you want to see him or his mother and father?
I think at any time we are interested in everyone suffering from IBD, UC, or CD at any age, and we have some consultations from outside. We can talk with Mayo, with John Hopkins Center here, there, and discuss with them the needs for early intervention and the need for special investigation. I think they are more and more convinced with different age.
Okay, so we cannot exclude, we excluded allergy and so, but because his father has a genetic Mediterranean fever and his mother had some non-specific colitis. So this baby should be put under good observation and follow up. And what is the follow up? Making regular or every 3 months calprotectin? What is the procedure?
I think the first is to be sure about diagnosis. The second is frequent assessment and getting the symptom control and even mucosal control if we can. But it's considered to be a very difficult case, and frequent and close doctor-patient relationship is an essential here.
Yeah, because above that we have patients at 7, 8, 9.
Yes.
This is not a problem. But this patient in particular, I am doubt about the diagnosis. Maybe, maybe another look. Congratulations for the lecture and congratulations for the good conference.
شرفتينا النهارده في البلاتفورم بتاع الاي بي جي ايديو دكتوره اميره، واحنا دايما بنطمع ان حضرتك تكوني معانا كده ومنورانا دايما.
والله انتوا اللي مشرفين.
ربنا يخليك.